نحييكم ونبدأ الجولة الثانية من الاكتيفيتيز اللي اتفقنا عليها، ان كل شابتر من الشابترز بتاعت الجمعية المصرية لأمراض وزراعة الكلى بيقدم لمدة يعني كل أسبوع برزنتيشن بتلخص الفيلوسوفي والابديتس بتاعت هذا الشابتر. الاسبوع اللي فات ابتدينا بالترانسبلانتيشن شابتر، والاسبوع ده بنكمل مع الهيمودياليسيس شابتر اللي انا بعتبر الحقيقه ان هو الكور بتاع النفرولوجي براكتس في مصر، لان احنا معظم الزملاء اللي بيشتغلوا نفرولوجي كلهم are involved on daily basis مع الهيمودياليسيس بروبلمز. وعندنا النهارده الاساتذه المسؤولين عن هذا الشابتر، الاستاذ الدكتور هشام السيد والاستاذ الدكتور مجدي الشرقاوي، هنتعلم منهم حاجات كتيره جدا وابديتس كتيره. وطبعا الدكتور هشام كمان عمل الفيرست بارت اوف الجايد لاينز بتاعت الجمعيه اللي كانت بتتحدث عن الهيمودياليسيس ان ديتيل، فبرضه يجب ان حضراتكم ترجعوا ليها سواء اونلاين او في النسخه المطبوعه بتاعتها، للي مش هيقدر يحضر كل البرزنتيشن او يقدر يعرف معلومات زياده عن هذا الموضوع. اترككم للمحاضره اللي اعتقد انها تبقى مثريه جدا للجميع، واترك الدكتور مجدي الشرقاوي يبتدي. يتفضل.
شكرا جزيلا دكتور هاني. بسم الله الرحمن الرحيم. طبعا انا يعني يسعدني النهارده اكون معاكم استكمالا لمسيره العطاء اللي بداها المرحوم الدكتور حسين شعيشة. طبعا النهارده معانا بروفيسور هشام السيد، استاذ امراض البطنه والكلى في كليه طب جامعه عين شمس، الصديق العزيز والاخ الفاضل، وطبعا العالم الجليل، واحد من اهم علماء الدياليسيس في مصر والعالم. الدكتور هشام طبعا غني عن التعريف. الدكتور هشام هو زي ما قال استاذنا الدكتور هاني هو اللي كاتب الشابتر في هيمودياليسيس ان ايجيبت، هو رئيس شعبه الهيمودياليسيس في الجمعيه المصريه لامراض الكلى، هو بورد ممبر في الجمعيه المصريه لامراض الكلى، وهو كمان رئيس شعبه الدياليسيس في الافران في الافريكان سوسايتي اوف نفرولوجي. خبره الدكتور هشام في الدياليسيس اعتقد ما فيش حد في مصر ما يعرفش قد ايه هو ديديكيتد، ويعني his intellectual work resulted in improvement في الدياليسيس في مصر. النهارده هيكلمنا عن الموضوع في منتهى الأهمية اللي هو dialyzer, how to choose a dialyzer, how to choose a dialyzer. This is a very important issue. و I think إن إحنا مهم جدا جدا هنتبع الخطوات اللي هنعملها الدكتور هشام عشان ما نضيعش وقت. الدكتور هشام بإذن الله يتفضل، والمناقشة هتبقى بعد المحاضرة. دكتور هشام.
شكرا جزيلا استاذنا دكتور هاني حافظ والصديق العزيز الاستاذ الدكتور مجدي الشرقاوي على المقدمه. Although some words of desperate feeling that to start renewing our session للبروفيسور والعالم الجليل الله يرحمه الاستاذ الدكتور حسين شعيشة، لكن we have to be optimistic ان احنا to continue. Thank you very much Professor Dr. Magdi for your kind words. يعني I think يعني ان انا لا استحق هذا كل الاثراء، لكن كلنا بنحاول بقدر الامكان ان احنا to improve our knowledge base من الخبرات الكبيره. لو اذا سمحت لحضرتك بس انك انت to share the presentation. Is it clear now? It's clear on screen.
نو لسه لا زالت لسه يا دكتور هشام ما ظهرتش.
Just انك انت تديني screen sharing. Share screen. Okay.
تمام ظهرت يا دكتور هشام. تمام مظبوط. تمام.
اوكي. بسم الله الرحمن الرحيم. We have to start on a clinical based educational mission for hemodialysis in depth. One of the main topics of that is how to choose a dialyzer. And of course, how to choose a dialyzer is a dilemma with a very big importance of information included. We will have to try and focus on the basics, not on secrets. There's millions of secrets inside. I will not touch that. We have to make up the talk in the basic components of a dialyzer when a dialyzer is innocent. And it's very important for clinician because don't rely a lot on the dialyzer if you have inadequate dialysis. We'll touch that later. The functionality in depth, including clearance, KOF, transmembrane pressure, dialyzer fiber configuration and the urology, and hemodialysis membranes. And finally, we will have some issues about the requirement of a dialyzer for hemodiafiltration. So let us start with some important messages. The following information are essential for a nephrologist who is managing, driving, and operating hemodialysis unit. You cannot take the task force of a hemodialysis unit without the knowledge base of how to choose a dialyzer. It's not an optional, it's a must. And selecting a dialyzer is only a piece in the puzzle of hemodialysis adequacy. We will continue our CMA on hemodialysis, how to improve the adequacy of hemodialysis in multi-functionality and the multi-target approach. But today we will focus on the dialyzer. And if you go back towards the globe more than 10 years ago, when you are comparing high flux versus low flux, when the membrane permeability outcome had been started more than 12 years ago, that high flux should be preferred in patients on regular hemodialysis. And a couple of years later, the European best practice guidelines stated that high flux should be used to halt and delay the complications of retention of middle molecules in dialysis population. So there is no, up to now in 2020, we cannot say low flux versus high flux. It's now the modern hemodialysis currently, it's changing between high flux versus hemodiafiltration therapies, while low flux hemodialysis should consider a history. And if you go to the hemodiafiltration, more than 20%, up to 25% in the Middle East as well in Europe are now on regular or routine hemodiafiltration. So one of the first message is low flux dialysis is an obsolete issue, and it's described perfectly in the guideline that all the membranes used in dialysis should be in high flux. And if you go to the dialyzer choice, you have differences in fluxes. Not all high fluxes are the same, so there is a difference in high flux. Considering the KOF or ultrafiltration clearance, sieving coefficient, sterilization types, should all have convection therapy capability, either high flux or hemodiafiltrations. Considering the surface area best fit for your patients, starting from 1.3 or 1.4 for the adult patients up to 2.6 square meter surface area, less thrombogenicity or less coagulations, biocompatible and easily handled, fitting different types for individualization of therapy. So globally, when you see that how to choose, you have to describe all these points in more details in each individualized dialyzer. And if you go back again to dialyzer, what is the spec you have to mention is the membrane, dialysis membrane type, the flux, high flux, super flux, medium cutoff or high cutoff, surface area, type of sterilization like gamma sterilization, electron beam sterilization, steam sterilization is the best for sure, performance like clearance data and sieving coefficient, and finally the thrombogenicity or clotting behavior during the hemodialysis session. So if you collect from a dialyzer this regarding these 6 points, you can choose in between very, very simply. And towards an ideal dialyzer is the best fitting to your needs. The selection of your dialyzer is at all is your importance for fitting to each individual patient. You have to start from each type of patient. For example, hypersensitivity reaction would happen from one to another type of dialyzer. It's not the defect of dialyzer, but it's the patient individualization. And the ideal dialyzer should have better overall score. You can do a scoring techniques in selection. For example, the ultrafiltration, the clearance value, the sieving type of sterilization, and for sure it should be in a cost-effective manner.
Excuse me, Dr. Hesham, please, can you raise your voice, please?
Okay, that's good.
Thank you. Thank you.
So if you go to ideal dialyzer, should have no sterilization residuals, especially in patients using gamma sterilization as a lot of sterilization residuals. Steam is much better. It should have higher endotoxin retention capacity. We will touch that later, but important to have a dialyzer with safety measure as well in endotoxin transfer, and easily priming and easily wash out during clinical use. So this should be globally the ideal dialyzer use. And a dialyzer is characterized by 6 Ds. It's a medical device having downstream blood flow. It should be optimal with better dialysate to blood matching to optimum clearance values, and drive the session efficacy. Determining the dose of dialysis is one part from the dialyzer and should have both a diffusive and a convective transport. So these are the characteristics of a dialyzer with the 6 Ds. It's a device, blood flow downstreaming, dialysate blood matching, drives efficient efficacy with augmenting the dose of dialysis as well as the capability of diffusive as well convective transport. When a dialyzer is innocent, sometimes the clinicians say that the dialyzer is inefficient. Indeed, the inefficiency is coming out of the dialyzer, and the dialyzer here is innocent. If you do imperfect priming, you have to get some time for priming, inadequate anticoagulation. If the dialyzer is a small size for patient weight, and if you are using dialyzer in a very low blood flow rate, if the arteriovenous fistula has a recirculation, or you do a short dialysis time. So this is overall saying that the dialyzer is innocent if any of these points is occurred during the dialysis session. And this is the innocence of the dialyzer could be device-related factors, doctors or nephrology-related factors, patients as well related factors. When a dialyzer is innocent, particularly important in clinical use is the recirculation. And we have 2 types of recirculation. The short loop, which is the commonest knowledge-based information, is the vascular access recirculation. While sometimes you have a long loop recirculation when you have a cardiopulmonary recirculation within the cardiovascular system, meaning that the fistula carrying more than 30% of the blood flow from the cardiac output, saving that to the vascular axis, does not reaching the organs to wash out the toxins. And this cardiopulmonary recirculation is well-known phenomena, and in particular in long-standing patients with aneurysmal dilatation and the blood flow of the fistula more than 30% of the cardiac output. So this is very important to check the fistula either for low flow and recirculation as well very high flow with a cardiopulmonary recirculation. And this is a diagrammatic presentation for the flow from the dialyzer to the heart, and it should go to the systemic tissue. However, if the fistula flow is high, it goes back to the dialyzer, bypassing the systemic tissue, subsequently leading to inefficiency of the dialysis. And the vascular access recirculation is mandatory to be tested in patients does not related to the adequacy, particularly urea reduction ratio, although you optimum your therapy by the dialyzer specification as well the hemodialysis and the time. So this is a rebound important, does not be criminal for the dialyzer. It should be innocent if you have an axis recirculation, if you have a cardiopulmonary recirculation, as well if you have a poorly accessible compartment. That's why sometimes exercise during dialysis improve the overall adequacy simply by improving the tissue perfusion during the dialysis. So coming back again, it's now the era to do high flux versus hemodiafiltration. You have to review the CV coefficient of the dialyzers, reviewing the ultrafiltration. We will shortly highlight some of the brochures or data from the companies. You have to check the performance, review the clearance, and fitting the surface area for individualized patients. So if you are using high flux versus hemodiafiltration, you have to review all the data of the dialyzer before putting that on the machine. And the manufacturing data to be informed that are in vitro testing, use aqueous solution, not blood. So it is not on clinical use as exactly as described in the brochure, because they are using aqueous solution. While in clinical use different with different blood hematocrit, higher blood hematocrit is reflected by lower clearance because of lower plasma water, duration of hemodialysis, and other hemodialysis prescriptions like QP, UD, and time. So this is the manufacturer clearance value using aqueous solution, which mean usually below 20% higher than the happened during clinical use. Lower value as plasma water percent, sieving coefficients for small as well for bigger molecule, with advantage of higher sieving coefficient, especially for hemodiafiltration. Ultrafiltration coefficient determine the transmembrane pressure applied in hemodialysis and related directly to a pore diameter. And if you go to the manufacturing data, a lot of data inside the brochure, we have to read them carefully. Most of the brochures containing the membrane type, like here polyamides, polysulfone, polyether sulfone, the footing are all the same. It's made of polyurethane. The housing, probably polycarbonate or polypropylene, have a protection caps, but this sterilization, some are steam, some are gamma, some are e-beam. And if you go to the specification, you can find that ultrafiltration coefficient per millimeter mercury. This is important because higher KOF is important in hemodiafiltration. Sometimes you describe the diffusive permeability of small solids like urea. All the dialyzers are now has a high KOF of urea, meaning that very high efficient. Meaning that high efficient dialyzer is not a high flux. High efficient mainly is related to urea clearance, not to the flux. And the blood compartment volume, the dialyzer can accommodate around 100 milliliter of blood. And you can find here the data for clearance. For example, urea phosphate creatinine, this is the molecular weight, and this is the blood flow against the dialysis flow. When you're going from the 200 example blood flow to 400, the increase in clearance is not linear. It is not doubling because the clearance is not a linear correlation with the blood flow. Above 400, usually the clearance stops from that. And if you are going to do clearance value on 500, you have to increase the dialysate, which is impractical for use during clinical application. This is the urea, phosphate, and creatinine. And as well for the middle molecules like vitamin B12 and aniline. Aniline is not a toxic inside the body, but it is a marker of the middle molecule because the molecular weight is 5,000. While vitamin B12 is not removable freely inside the dialysis because it's a store in the liver. So giving a lot of vitamin B12 because it's removed dialysis is not a correct scientific information. You can have a surface area, for example, 1.4, 1.7, 2.0, whatever. You have a sieving coefficient parameters. Look for that. beta-2 microglobulin, myoglobin, as well albumin. Both are correlated to each other. You can find very high sieving coefficient of middle molecules, but has a very high loss of albumin. So this should be concise as well, higher middle molecules removal and decreased albumin loss. Still, there is a lot of manufacturing data here from different companies, sometimes using the cytochrome C because it's correlated to beta-2 microglobulin, the same molecular weight. Sieving coefficient, different companies, as well albumin, myoglobin, and aniline with albumin sieving coefficient with different molecular weight. And you can find some difference between each device or each dialyzer according to the molecular weight of sieving coefficient. This is very important if you're using hemodiafiltration. You have to use a sieving coefficient higher to remove the middle molecules, especially now kappa and lambda are considered one of the uremic toxins, and the molecular weight is exceeding 40,000 Dalton. And this severe coefficient of myoglobin may sometimes needed, especially in the era of COVID, because myoglobin molecular weight is identical to interleukin 1. And so removing cytokines is important in COVID patients. So these are different parameters you can read about, and you can compare between different companies to choose the best fitting, choosing the surface area up to 2.6 square meter dialyzers, sterilization type like wood steam or gamma sterilization. Personally, I prefer steam, more friendly in the clinical use. And on clinical studies, you can find different dialyzers with different albumin loss, beta-2 microglobulin and myoglobin. So put the 3 points important in the selection of high flux if you check the albumin, beta-2 microglobulin, as well as the myoglobin. You can find here some dialyzers have very high myoglobin, but still have a very high loss of albumin, while others have some moderate myoglobin removal and very low albumin loss. So you can choose between the 3 points and intermediate between the loss of the important albumin or the loss of the toxin. So this is the clearance value of sieving, removing what we know and what we don't know in the middle molecules era. And if you go back again to the clearance value, you can find difference of the clearance between different surface between 1.0 and 2.0. It is a lot of increasement of the blood flow, increasing as well from 200 to 300 and increasing according to the size. So both increase in clearance related to horizontal increase in the surface area or in the vertical increase in the blood flow. Both of them are not linear, meaning that you cannot double the clearance by simply doubling the QP. So this is the some of the manufacturing data. I hope that we all can read carefully. And if you go to the fibers dimension, it's in between 185 and 220, with the ideal one lies between 200 micron to increase the smoothness of the blood flow. And you can find some of the KOA value depending on the surface area as well. When going to endotoxins, we all know that endotoxin can be generated from the water treatment. And some dialyzers have the potency to have the endotoxin retention capacity. And this endotoxin could be absorbed on the wall of the fiber itself. With the most important of that is the polysulfone is the golden standard in endotoxin absorption capacity. And you have to respect that. we have to respect the flow from the blood side to the dialyzer side, meaning the clearance or removal. And we have to respect the other side when endotoxin transferred from the dialyzer to the blood side. And this is the photo of immunofluorescence or fluorescence techniques of the endotoxins absorbed on the wall of the fibers with different types. So you can ask the manufacturing process if you have an endotoxin retention capacity or not. And this is, of course, will be added to the score of your choice. So dialyzers, in simply, is a bidirectional way of removal of toxins and removal of potentially important substances. I always say that dialysis is a blind, cannot differentiate between which is beneficial and which is drawbacks. And on the other side, we have to protect the bloodstream and the patient from the microparticles or endotoxins transferring from the side, with advantage of some membranes over others in selection of the dialyzer that absorb endotoxin and giving a safe more on others. So the ideal membrane should be biocompatible, less thrombogenic, optimum ultrafiltration, preferably fit for hemodiafiltration, excellent diffusive and convective properties, resistance to chemical and physical sterilization with an optimal permeability profile, should allow high sieving for large solid with minimal or absent or albumin loss. This is the ideal membrane or ideal dialyzer. And we have to mention that again, convection is not an optional in our daily test therapy, because convection is essential for removing the middle molecule. So selecting the dialyzers with lower ultrafiltration or lower sieving coefficient will affect the adequacy of hemodialysis, in particularly the beta-2 microglobulin and above. So ideal dialyzer should have a plenty of convection therapy that makes sure that your patients are removing the middle molecules more efficiently. And you choose the rule of the thumb, big for the big, small for the small. It is not the same because, as you know, a lot of debate on the dialysis adequacy, KT over watt and KT over V. But on the optimum condition, we have to do KT over surface area, meaning that surface area plays a major role in deciding the dialysis adequacy by controlling the dialyzer surface area, big for big and small for small, and your clinical judge should be at the end the point of decision. So choosing a dialyzer, it's not an option. What the clinician should know, you have to improve the dialysis prescription in general by high flux, improving anemia, improving nutrition, improving and controlling the volume, controlling the blood pressure, and treat any inflammation. So dialyzer is not a magic therapy. It is one of the devices you can control, but a lot of issues in dialysis should control. One small piece in this puzzle is using high flux membranes. So looking in depth inside a dialyzer, originally the term flux was defined by the ultrafiltration coefficient. In the past, in 1989, when FDA defined the high flux or high permeable dialysis membrane related to ultrafiltration of 15. Nowadays, we have a low flux with an ultrafiltration more than 15. So it is obsolete classification of flux depending on the water or hydraulic permeability. The high flux in modern is characterized now by beta-2 microglobulin sieving coefficient. So any dialyzer with a sieving coefficient more than 0.6 should be considered a high flux. Below that is not considered a high flux dialysis. And the high flux and the protein leaking membranes both are not the same, because protein leaking, the albumin loss inside the dialysis station exceeding 60 grams per session. So I don't recommend at the moment for the protein leaking membranes. However, with the COVID era raising this medium cutoff or what's called protein leaking membranes, to ensure more and more removal of cytokines and preventing the cytokine store. So protein leaking is the one side is the biggest part of the high flux, whereas the pores are bigger, removing much more of the toxin molecular weight. Instead, we have a very high albumin leak, around 6 grams per session. While in the Japanese perspective, are classifying the membranes where they decide that the high performance membrane, please note that it is not a high performance dialyzer, because high performance dialyzer depending on urea. However, high performance membrane, meaning that you have a very high porous membrane, still the albumin loss is around 3 grams per session. And they classify that the dialysis or the dialyzers into 5 classes according to the beta-2 microglobulin clearance. The Japanese are superior in that because they go and they of course have the perfect survival, less complication, and giving the patients the right to use high performance membrane or class 4 to class 5. Next to this slide is important to Egypt and in many of the other countries, where it's called the rule of pay for performance. I, as a caregiver, I will pay for the suppliers or I give for the centers according to the quality of that, not all the fixing. What's happening in Egypt, if you are using low flux, if you are using high flux, both are the same in pricing. If you are using a medium cutoff, or if you are using small dialyzer, on the other hand, you have the same pay for performance. So I think one of the major points we illustrated in our Egyptian guidelines is the new TPS, or the performance scoring for each dialysis center. And the next step, probably years later, we would go to the pay for performance, and this is applied in Japanese. So the high performance membranes are excellent, effective, push size are larger, and should help to have a higher molecular weight cutoff. And if you go back again to the KOF against transmembrane pressure, this is a very important equation if you are using hemodiafiltration, because a dialyzer with higher ultrafiltration will have a lower transmembrane pressure. And it's important in clinical use because you have to freshly preparing that the membranes for continuous over 4 hours of hemodiafiltration. So KOF is important. And it is not a fixed. If, for example, if you have a patient with higher hematocrit, the dialyzer performance is lower in performance in clearance as well in ultrafiltration. And this relationship within the ultrafiltration, depending on other like parameters, blood flow, dialysis flow, filters flow, fiber flow or geometry, and the patient parameter. If you go to the left panel, you have a blood compartment and blood composition, hematocrit, and the protocrit. I understand that protocrit is not a common name used, but it defines the serum proteins inside the blood. It is against the ultrafiltration, as in our individual capillaries, the uncoated pressure, and as well, it is against the clearance because the protocrit decreasing the plasma water. So both hematocrit as well protein content of the blood or protocrit, both can changing the parameters of dialysis, considering the ultrafiltration as well considering the performance. And it is not linear. You cannot find that a linear relation. And this is important as well in hemodiafiltration. If you have a higher transmembrane pressure during the session, you will have the membrane fouling and the membrane coating with proteins, and the hemodiafiltration process is suboptimal. And this is called the transmembrane dependent zone. So please, if you are doing hemodiafiltration repeatedly, check hourly the transmembrane pressure, and if exceeding 200 millimeter mercury, be sure that your session of hemodiafiltration is not excellent. You can change the dialyzer type, or you can increase the dialyzer surface area. The limit of 200 millimeter mercury is important to avoid complication and fouling of the membrane during hemodiafiltration. Please consider this figure as important in your follow-up of the hemodiafiltration session. So ultrafiltration, depending a lot of issue, I will not go into the details, but please read carefully the UF of each individual dialyzer to see that it's fitting the substitution volume or not. And it is not linear. When increasing the transmembrane pressure, you will not have a higher ultrafiltration. It is not a linear correlation. So the dialyzer packing, fibers inside, and the fiber arrangement, I call it fiber makeup. It's like a makeup in everything. You have to optimize the blood flow inside. You have to optimize the resistance of flow and the dialysate, and we have to increase the flow inside the dialyzer. Please note that inside the dialyzer, the speed of blood in the periphery is nearly 50% of the flow inside the center. So if you are using a big dialyzer like 2.0, for example, and you are matching the QP to 200 milli per minute, be sure that you will not have a benefit because the blood flow is very, very slow and we will have clotting. So matching that, increasing the blood flow during QP is mandatory for bigger dialyzers, especially that dialyzers with characteristic of blood flow inside is not optimal. So usually the central part is increasing in flow, while the peripheral part is decreasing in flow, and that's why we can see some streaks of blood clotting at the end of the dialysis session due to stagnation of blood flow in the peripheral part. And this is the optimum special design for that to improve the flow, and this is a characteristic. This is our daily basic practice when you can see a clear dialyzer and others are streaky and other has clotting. I understand that it's a lot of issue considering patient-related factors like hematocrit, improper anticoagulation, excessive ultrafiltration, all are exactly causes of blood streaking during dialysis. So this is the assessment, a lot of the study. Again, we have to respect the performance as well. On the other hand, the endotoxin retention capacity. And I did that in the lab of research. Yes, it can help. Retention capacity with millions of endotoxin could be retained inside the dialysis membranes. So you can ask on that of different brochures if the filter has capacity of endotoxin retention or not. So this is the past 3 years. Dialyzers is different with the structure difference, but the same has the same concept of blood flow, dialysate flow, and fiber arrangement. And fiber numbers here coincide for the surface area. Around 10,000 fibers, at least, inside the dialyzer or filter for 1.4, 1.6 dialyzer and going up to 20,000. Sometimes we have dialyzer with around 15,000 fibers inside in very big dialyzer. Some have below that. If you have 1.3, for example, you have around 8,000 fibers inside, and this is the linear. If you increase the size, you increase the number of fibers. If you stop here for the dialyzer, same dimension. So this is especially mathematical conditions of the number of fibers inside correlated to the surface area. And all the fibers are related to nanotechnology, improving the porosity, removing much of the toxins, and still, on the other hand, decreasing the albumin loss. Improving the design is one of the secrets, company secrets, to improve the flow inside. Because as we described, the central part of the flow is optimum while the peripheral part of flow is suboptimal, and the design of dialyzer is important. You cannot check that as a clinician. You can find that on clinical use, by all means. Sometimes you have a blood leak, and this could be related to manufacturing process or transportation. And this is a blood leak could happen, but it's safe. It carries no risk. Others, complications like air bubbles could be happen. And these air bubbles may come from inadequate blood flow or a defect in the priming of the dialyzer. One of the issues I consider that important is the sterilization type. You have a steam, either autoclaving, or you have a gamma radiations or electron beam. And now I think it's obsolete now using ethylene oxide. All we know that on ethylene oxide was 20 years ago when using ethylene oxide, and they have a first field syndrome with back pain and chest pain starting immediately after starting dialysis. Now we consider steam and radiation are the perfect, and steam or heat sterilization is the optimum, followed by radiation, and ethylene oxide is now obsolete. The pharmacopoeia for autoclaving is important. Autoclaving is the same like in autoclaving in the hospital. You are doing sterilization of the dialyzer at 121 for at least 20 minutes, ensuring efficient time, continuous steam inside, sterilizing the dialyzer from in and outside. While radiation sterilization induces structural modification. So radiation sometimes can release cytotoxic components, while steam sterilization is a reference in terms of security for thermostable materials, and benefits of steam allows the removal of waste generated during dialyzer manufacturing. Again, we have to focus again on priming. I will leave you on this half-a-minute video just to break out the very tough talk on the dialyzer. For the clinician, you have to check with nurses the air removal during priming, because it affects the performance, could induce clotting, and the session will not be happy on that. So improving the performance and subsequent ultrafiltration and urea reduction ratio, you have to optimize the priming technique, sufficient time, sufficient fluids, deaerating the dialyzer from fibers. Preferably, you do as well priming of the dialysate compartment by passing for a couple of minutes dialysate flow as well before connecting the patient to remove any particulate from inside or outside, as well from inside, or deaeration. And if you don't do better priming, you will have clotting for sure. So this is the membrane. We prefer to be hydrophilic, meaning that hydrophilic criteria of the membrane will prevent protein adsorption. And if you have a protein adsorption layer, which is called the boundary layer, will make the dialysis consistency or efficiency incorrect. So you have to starting the dialysis efficacy by perfect, but with time, the dialysis efficacy drop due to deposition of protein inside the fibers. You cannot detect that on clinical base, but you will not find what you wish from the clinical practice of the urea reduction ratio or middle molecule. So sometimes patients used are more complicated with hydrophobic membranes, and this is for sure are obsolete when starting the polysulfone membranes. Probably 40 years ago, the membrane was hydrophobic and induced a lot of complication. Now all the membranes are more hydrophilic. And this optimizing the clinical sessions by decreasing the protein adsorption inside. In order to illustrate that, This is from inside the blood flow of the dialyzer. You'll find a lot of blood coming inside. Red blood cells, proteins, electrolytes, minerals, toxins. And if the membrane is hydrophobic, you'll find a lot of absorption of protein inside, clogging or obstructing the pores, and dialysis efficacy will not continue. How you can detect that on clinically? You will find on hemodiafiltration a raising up transmembrane pressure during the session. You can reach 300 millimeter mercury. For sure, this membrane is protein absorbent. On a session of hemodialysis machines, we would describe how is the automated form of hemodiafiltration solve this issue, because it's learning and crosstalk between the dialyzer and the hemodialysis machine, considering this important issue in hemodiafiltration, one of the new techniques inside that. Dialyzer fiber geometry, meaning that the criteria of the fibers, some fibers are micro-undulated, meaning that are not straight. And if it's straight, it's packed inside the dialyzer. You have a lot of dead spaces in between the fibers. The dialyzer cannot be in between. So in the modern dialyzer, we have a micro-undulation. And this micro-undulation will keep you on this video. Again, I worked on that probably more than 15 years ago on the clinical and manufacturing process of micro-undulation. And I think this is one of the new technology applied. The blood flow inside, the fibers are not straight, and the fibers are undulated, meaning that with angling, and this angling, not tucking fibers on each other, giving a space between each individual fiber to be in a full path of a dialysate. So you can perfectly benefit from the total surface area you pay for if the fiber are micro-undulated. While doing so, it is in character, it looks inside the dialyzer clearly if it's micro-undulated or it is straight. I prefer that if the fibers are micro-undulated, or on the other technology using some of the spacer or separating the fibers by either way. So efficiently, you can find all the blood flow inside the fibers are matching with the dialysate. So this is a micro-undulation, and this is what's called the spacer to separate each fiber from each other. And this is a spacer yarn or micro-undulation, one of the beneficial geometrical of the fibers inside, and a lot of study on that. And if you go to the different imaging techniques, you'll find that the matching of the blood and dialysate, just to messaging you that the undulation and the spacer yarn are important in performance, because it separated the fiber from each other, making no spaces between the dialysate as well the blood side. Going to an important issue, which is the sieving coefficient. Not all high flux are the same. Look again to the sieving of albumin, sieving of myoglobin, sieving of beta-2 microglobulin. You can have a lot of membranes. Low flux is obsolete. High flux is not all the same. You have eyes wall, medium cutoff, and high cutoff, meaning that removal of solids from the high flux is different. Back again to this first slide I presented in the earlier, not all high flux has the same sieving coefficient. You have to read carefully the sieving coefficient of the three parameters, the albumin, beta-2 microglobulin, and the myoglobin. And you can find the difference in between. While high flux membrane differ from medium cutoff, because medium cutoff can remove very efficiently molecular weight up to 50,000. And again, medium cutoff come to light after the COVID, because medium cutoff dialyzer is equivalent in hemodialysis mode as in hemodiafiltration with others. But remember that don't mix, again, don't mix medium cutoff with hemodiafiltration technique. Because if you are using medium cutoff membranes and doing hemodiafiltration, you will have a great albumin loss. So hemodiafiltration with high flux is nearly equivalent of medium cutoff membranes in high flux techniques. Don't mix between medium cutoff in hemodiafiltration. Both cannot be combined together. While high cutoff, although the first literature was promising, but the albumin loss in practice exceeding 20 grams per session, which is huge, and it's now declining from the market or declining from literature. I think I don't like the high cutoff from the start, and nowadays there is no indication for high cutoff. All what you need is high flux with higher sieving or medium cutoff in high flux techniques. Dialyzer hypersensitivity, we'll talk about that in details, but it's related to dialysis membranes. It is not a defect in the membrane. It is the hypersensitivity of the patient. But you can check, although the progress in dialyzers is still recorded data of hypersensitivity is increasing, coming from very mild to even anaphylactic reactions. Shifting from one flux or one membrane to other can solve. If not, you have to check again the priming technique and the other causes of hypersensitivity, probably from heparin or from blood tubings or from fistula needles, sometimes from other fluids can do hypersensitivity reaction. I think this should be one of our next topics to be in more details, because it's important to be in our knowledge base how to diagnose and how to treat. Coming to our last part of the talk, just a few minutes, my friends and colleagues, hemodiafiltrations. We are all known that I think most of us are doing hemodiafiltration with a filtration fraction going to substitution of about 25 liters inside post-dilutional and 50 liters in pre-dilutional. Taking that too much high fluids, you have to define carefully the dialyzer prescription inside hemodiafiltration. Limiting factors for high volume online hemodiafiltration could be the membrane is small sized, or the pore are small, or the surface area is small. You will not get the target. So increasing the dialyzer surface area, increasing the KOF of dialyzer, increasing the sieving coefficient of dialyzer will have more effective hemodiafiltration. Your requirement should be a high flux with better sieving between 1.6 to 2.2, and even in France using 2.6 square meters. Preferably, fiber internal diameter should be more than 200 to ensure smooth blood flow. Sieving coefficient should be identified with lower albumin loss. Vascular access is important to have efficient blood flow. Here's a target of post-dilutional and pre-dilutional. Ultrafiltration control should be optimum, because increasing the transmembrane pressure will increase the fouling and membrane clotting. That's why most of the modern hemodialysis machines carrying out hemodiafiltration are doing in an automated mode. It meaning that if you're increasing the transmembrane pressure, it defines that the filter is blocked and stop ultrafiltration, doing flushing to regain tiny, removing protein absorption and regaining back the healthy membrane to continue hemodiafiltration. And this is the difference. I am suggesting that never to convert from automatic mode in hemodiafiltration to manual mode. Just look for the goal of substitution as well of the transmembrane pressure during the session with best filtration fraction of hemodiafiltration. This will be discussed in details. We will discuss in details the hemodiafiltration. I know that most of consultants and colleagues have their own experiences in hemodiafiltration. Nowadays, we would share our information on that on the next discussion. So in conclusion, professors and colleagues, dialyzer selection is a multifactorial decision. It's your own decision based on information. If you are a manager or a director or even a junior or a tender planning, it's your decision to choose based on a scientific information, not guided by fake information. And depending on the Egyptian guidelines, all dialyzer should be in high flux membranes. It is not now a story, it is a fact. Selecting one over other dialyzers depending on the targets, surface area, permeability, hemodiafiltration. Dialyzer with higher KOF is preferred for hemodiafiltration, while least sieving coefficient of albumin, not more than 3 grams per session. Dialyzers fit for hemodiafiltration as well high flux dialysis should have sufficient sieving coefficient to remove middle molecules, including myoglobin sieving coefficient. Thank you very much. A lot of secrets are still inside. I just touch up these topics. More information are still inside, and hopefully we are all staying safe. Thank you very much.
Thank you very much, Professor Hesham, for an elegant and very comprehensive presentation of how to select the dialyzer. And I'd like to hear from Professor Hani Hafiz first before the questions.
Thank you very much, Professor Hesham. Very, very illustrative, starting from the depth and going, making it very, very simplified for everybody. Thank you very much. I wanted also, before we start the discussion, because you have a very big experience in COVID, what type of dialyzer you recommend for a patient who got COVID and has got an acute renal failure? Do you recommend a specific type of dialyzer, or every type is okay? Because there are some publication of selecting some special dialyzer types.
It's exactly, it's a very important, Professor Dr. Hani. It's a very important, and we described that in our COVID guideline with Professor Muhammad Salah and Professor Hussein. I described that carefully, that if you are using in acute kidney injury and you are using SLED technique or prolonged intermittent renal replacement therapy in such patient, you have to be sure that of the sieving coefficient of myoglobin. And you have to look on that, because you have to ensure on two main issues. One issue is higher sieving. Second issue is prolonged time to compensate for the continuous production of cytokines. So selection, depending on the sieving coefficient of myoglobin, it should be above 0.5. Actually, in the market, there is at least 3 types of such dialyzers, starting from 0.5, 0.6, and 0.7. And the 3 types are available in Egypt. If you are going higher, like medium cutoff, it is not available. And I don't prefer use of medium cutoff in hemodiafiltration techniques, although some literature saying that we can use it in COVID technique. So my answer to your elegant question, important question, if you have a patient with a COVID, with acute kidney injury, you have to select the dialyzer, not the surface area, because in any case you are doing prolonged dialysis, probably may have a lot of complications like clotting. Don't go to a big surface area, go to a smaller surface area, but with higher sieving coefficient of myoglobin. In the market, 3 types of the Egyptian market are available. Just ask which is the higher sieving coefficient of myoglobin.
Thank you very much.
Professor Hesham, there are a lot of questions. I'll start with the first one, which is not related to dialyzer selection, but you said you'll answer any question. The question is about AV fistula toxicity.
Yes, it's a big issue. AV fistula in general, from AV fistula first, AV fistula toxicity. I know that probably 10 years ago, you give a lecture talk to Magdi from AV fistula toxicity. What I mean in my talk is, don't blame the dialyzer in all occasions. That's what's happening in some of the juniors, saying that the dialysis is inefficient because the dialyzer is inefficient. On the other hand, you have an AV fistula toxicity. We have a very high flow, and this high flow coming more than 30% of the cardiac output. You are not refreshing the toxin removal from the tissue because most of the cardiac output go to the fistula. So I think two parameters is important on the two arms or two extremes. Either low flow is dangerous for improper performance, and very high flow as well is improper for performance.
Okay, there is another question about the normal range of venous pressure, arterial pressure, and TMP.
Depending on the techniques and depending on the flow, in practice, the arterial flow or arterial pressure is a negative pressure. It is a pre-pump pressure, and it should not exceed 250. At a blood flow more than 300, 350. And if you go, this is arterial pressure. It's not in common clinical use here, but this is a standard. If you got more than arterial pressure, more than 250, meaning that you are using a needles with short, small pores, or you have a problem in vascular abscess. On the other hand, venous pressure, I think the upper limit of 200, 250 is accepted, because if more than these figures, resistance to flow from the dialyzer to back again to the patient would affect the coagulation, would affect the membranes, as well will affect the overall performance of the session.
And so the higher venous pressure will affect the dialysis quality.
Definitely, you will have clotting, you will have alarming, you have clotting in the chambers, development of micropupils, which can pass the air trap, giving pulmonary hypertension to your patients. So there's a lot of complication outside the circulation. You will have a problem later on with the patient.
So what are the effects of different dialyzer material on TMP?
Okay, if you, as the equations saying that the transmembrane pressure is related to QF and ultrafiltration rate. So if you have a higher QF, for example, in high flux mode, will not differ the transmembrane pressure. Both of them will be very minute. I'm not talking on low flux, but if you are using hemodiafiltration technique, here QF will differ, because you need transmembrane pressure to do at least 6 liters per hour ultrafiltration. So there is a correlation between the QF and transmembrane. Have a high QF, you have a lower PMV, and on the reverse.
Okay, there is another question. Is there any evidence for the use of aspirin or Plavix to substitute or decrease the dose of anticoagulation given in hemodialysis?
The difference in pathway, it differs completely from platelets as well from the coagulation. It's a different pathway. Even in dialysis, especially with polysulfomembrane, it is described a lot that thrombocytopenia or thromboasthenia could happen during dialysis. So if you are giving aspirin or Plavix, it is for your heart, your internal vessel, it is not for the fibers. You are not treating the fibers by aspirin. So the difference, the different pathways are complicated. But in dialysis, in general, sometimes happen thrombocytopenia at the start of dialysis, especially with polysulfomembrane. I don't think that treatment with antiplatelets could solve the fiber coagulation. It's another pathway.
There is another question. Is there any correlation between intradialytic weight gain and the type of dialyzer?
This is the very, I think this is a question I think, scaring me for that. If you are doing better dialysis, you have a better nutrition, you have a better appetite, you have a better intake. But I mean here the fluids. If you are doing less dialysis, you have a feeling of thirst, and you have a uremic frost. You will have a lot of drinking. So both conditions, if you have a low efficient or high efficient, you will have a high volume intake. So it's not related to each other.
To complete this question, the same physician asking you, and what about the cardiovascular outcome of the laser selection? Is there any difference?
Sometimes, probably 5 or 6 years ago, one of the pioneer of the dialysis described their membrane as a cardiovascular protection. And I give a talk on that probably 5 years ago, the cardiovascular puzzle during dialysis, whatever it is the normal or sequence as a normal population or specific for uremic patient. There is no up to now what's called cardio protection. But as you know, your patient is multifactorial, different metabolic profile, different atherosclerotic influences. Like if you go to the dialyzer specific, both are the same if you are using high flux membranes.
There is one question we used to answer in the past. Is there any equation that link body weight of the patient with the minimum size of filter that can be used, or shall we depend on URR and other well dialysis parameter? I think you mean other parameter of dialysis adequacy.
To my knowledge and my readings, there is no any equation on that. It's by trying different surface area, not affecting the time, not affecting the patency of arteriovenous fistula, and you decide to raise up the dialyzer or not. But the rule of peak to peak is the same here. You cannot put 100 kilogram patients with a dialyzer of 1.4 or 1.6 even. You have to go up and up and up to ensure that flow. But remember that increasing the surface area should increase the blood flow. You cannot have a very big surface area and still your blood flow is 200 or 250. You will not get benefit. You are paying for nothing. So the rule of thumb, peak for peak, I think it's applied, and your clinical as well, the adequacy landmarks as KT over V or beta 2 reduction ratio is the final target, whatever the surface area.
So let me ask you a very important question. It's not asked, but it usually come to us in the dialysis unit. In a patient with a small-sized adult or low body weight, we'd recommend smaller filter because they are afraid of older filter will cause hypotension. Is this true?
No, it's not true. I memorized our meeting in Budapest while I launched the biggest surface area dialyzer inside the market. Up to now, it is 2.6 square meters. The difference in priming volume or the volume of the filter is tangential between different. For example, if you have 1.3, you have 100 milli. And if you have 2.6, it's around 150. So if you have just a very small tubing, excess tubing part, the tubing system or the blood lines exceeding 250 milli. So I think the tangential increase in the blood volume inside the filter is not the cause. On the other hand, you can do that by better priming and flushing the patient with normal saline at the start if it's indicated, but it will not affect the hypertension at all.
This is very important issue because if you remember when we were in Dallas in the annual Dallas conference, it was raised that patients with low size, low weight, and children and women are getting less dialysis. And in our country, they are considering them for less surface area. So you have to correct this knowledge for everyone.
That's why in one of my talk of adequacy, KT over surface area, not KT over V. And KT over surface area will solve either a small-sized patient or in females. So this is not in clinical use KT over surface area, and sometimes we use KT over energy expenditure. A housewife should not take a dialysis dose like a man who is working, going every day to his work. So energy expenditures, surface area is mandatory parameters of selecting the hemodialysis dose.
So what do you think about the dialyzing children 3 hours and less? Do you think this is correct?
One of our discussion, for sure, it's not correct. From my short answer, it's not correct. Nothing, either flux or membranes or surface area, is contrary to the time. Time is the fixed parameter, and I'm astonishing that on KT over V, the only small letter is a T, which is the most important part on this equation. The time is required to wash out the tissue from toxins. Rapid removal from the blood will have a rapid rebound, and dialysis overall adequacy is bad. So nothing to say that 3 hours is enough for any kind of patient.
Okay, there is another question here about protein loss. It is not good in hemodialysis patient, but it is sometimes good for patient with myeloma. I think you mentioned this is not for the ordinary dialyzer.
I'm sorry, there is a conflict in the question. We have to separate both of them, because albumin is not a myeloma, and albumin is bigger than kappa and lambda light chains. So let us talk that clearly. Albumin loss, according to Japanese and some literature, is limited to 3 grams per day and 3 grams per session. And 3 grams is the normal physiological turnover of albumin. So up to 3 grams will not have a complication. But remember, if your patient is not well nourished, have a hypoalbuminemia, go to pre-dilution and hemodiafiltration, because post-dilution will increase the loss. This is a scenario of albumin. Sometimes hemodiafiltration improves the albumin by increasing the appetite, improving the aromatic toxins. So the low albumin could be due to inflammation, improved by hemodiafiltration. Bad nutrition or retention of aromatic toxin, improved by hemodiafiltration. So if you have albumin loss up to 3 grams, it's okay. On the other hand, talking to myeloma, you have to use either media cutoff or superflux, because the cutoff value should be up to 50 kilodalton, which is the kappa and lambda. Kappa is the smaller, it's around 24. Lambda is bigger, it's around 45. So the membrane differ. And you know that we did that in our hospital in Demirbash with a membrane with higher saving coefficient for kappa and lambda light chains, and the patient improved from acute kidney injury on that. Better to be used in hemodiafiltration technique.
Okay, I have 2 last questions. The first is using HDF will only require ultra pure water. Is this correct?
No, it's not correct. Because hemodiafiltration, you need sterile dialysis. And I don't like the term water. We have to change to a dialysis, because you may have ultra pure water, but finally you have contaminated dialysis due to inside the machines or inside the tubing system inside your water treatment station. So let us learn from each other that to use ultra pure dialysis or ultra pure dialysis fluids better than ultra pure water. For the second point, if you are doing hemodiafiltration, you need a sterile dialysis fluid or a sterile dialysis, not ultra pure. The difference is the colony count, 1 per million. So the difference not in the toxins value, but it's the difference in the colony count. So using high flux, you can use ultra pure dialysis fluids, not water. And doing hemodiafiltration, you need a sterile dialysis fluids, not ultra pure alone.
So another question here is there any role of decreasing the QB and the QD and filter size in case of intradialytic hypotension or in patients with heart failure compensated and decompensated?
Decreasing surface area to what? You have a prolonged dialysis. You have another prescription, intermittent prolonged dialysis. You have a short daily dialysis. Nothing saying that decreasing surface area. Don't take the solution for the center. Do the best for your patient. So if the patient has intradialytic hypotension, please review his dry weight, review his medications, review water treatment, all the causes of intradialytic hypotension. On the other hand, if you have a patient who has a heart failure, review the arteriovenous fistula flow. If it's more than 30% of the cardiac output, you have to manage, close the aneurysm, improving the well-being. And if so, you are doing so, do more smooth dialysis, more prolonged, and more or less green ultrafiltration. The dialyzer size is not the issue in this type.
Okay, finally, there is a question about the effect of HDF on removing phosphorus. Is it better than hemodialysis? And is there any effect of cold dialysate on the performance of the membrane?
Very good, two questions. I don't highlight because it will be illustrated in other talks. Going to the first question, is hemodiafiltration is better for phosphate control? My answer, no. No high flux, not low flux, not hemodiafiltration, or not super flux. Because we discussed that 4 or 5 months ago on the kinetics of solid kinetics, and phosphor has at least 3 kinetic poles. Phosphor is very minimal, less than 1% inside the blood volume, and the rebound is very hard. So hemodiafiltration can remove up to 700 millimole of phosphorus during the session. High flux can remove 650, low flux can remove 600. So the difference is not. The difference is in the time of the session. Prolonged dialysis session will remove more toxin because it comes from the third pole, kinetic pole, which is a storage, mini storage of phosphate. So fluxes or hemodiafiltration is not the target of phosphate control, but the time is the target. For the second question, I think you just say it again, back again.
The temperature, the effect of temperature on the membrane performance.
This is another important issue. As you know, there is ongoing trial. If you are making the dialysate cool, more cooler, you will have a lower clearance. But this lower clearance, and it's a going research nowadays, the difference in performance of the session between 3.6 and 3.7 degree. The difference is tangential, and the cold dialysate is well fixed procedure to prevent intradialytic hypotension. So consider that it is equal, although on a secret, the lower temperature will decrease tangentially the performance or the clearance, but the outstanding of stability of intradialytic hypotension, cardiovascular, and even a lot of cooler dialysate is much outweighing the tangential performance lower.
Okay, thank you very much, Professor Hesham. It's a very interesting discussion, and I leave you with Professor Hani Hafiz to conclude this session.
Thank you very much, Professor Hesham and Professor Magdi. It was very important and illustrative session. الحقيقة يعني بيحضرني إن هو لا زال المرء عالما ما طلب العلم، فإذا ظن أنه قد علم فقد جهل. النهارده حضرتك قلت لنا حاجات كتيرة جدا، احنا فاكرين إن احنا يعني we are experts in dialysis، وواضح إننا نحتاج إلى المزيد والمزيد من المعلومات.
العفو يا دكتور هاني، حضرتك أستاذنا يعني.
الله يخليك. لا ده لينا كلنا إننا سنستمر في مسيرة العلم دي، لأن هي فعلا لا تنتهي. والحاجة اللي عايز أقولها إن احنا يمكن ما قدرناش المرة اللي فاتت إننا نسجل المحاضرة على اليوتيوب، لكن المجموعة الحقيقة كوردينيتورز ممتازين توصلوا لان هم المره دي عملوا تسجيل كامل، وهيبتدي المحاضرات تنزل على اليوتيوب بمجرد ان هي كل 4 ان شاء الله يبقى لينا لقاء مع بعض، بالاضافه الى بعض الجلسات الاضافيه يوم السبت او الحد مع الفورن سبيكرز اللي بيجوا من الولايات المتحده او من اوروبا، لان بيناسبهم اكتر الويك اند. فارجو ان احنا دايما نبقى متواصلين. النهارده كان الاودينس حوالي 100، فالحقيقه حسيت ان يمكن البلاتفورم اللي احنا مشتركين فيه اللي هو 100 ممكن يخلي بعض الزملاء ما يقدروش يخشوا على السايت، فنحاول من خلال الجمعيه اننا نكتر اكتر البلاتفورم لو امكن، حتى ده لو هيكلفنا فلوس اكتر شويه، عشان نسمح للمحاضرات المهمه ان هي يبقى لها اودينس يتعدى ال 100 حضور يعني. بشكركم لان ده من الريكوردز الكبيره او الاعداد الكبيره اللي حضرت النهارده.
بالتوفيق. ان شاء الله احنا كونتينيو يعني الهيموداياليسيس talks. We have a very eminent speakers from different universities, very professional hemodialysis. وان شاء الله نعمل a good work on that by collaborations of our friends from different universities ان شاء الله. I hope that all we staying safe وربنا يسهل ان شاء الله. كل سنه وحضرتك طيبين ان شاء الله.
انتوا بالصحه والسلامه، ومتشكرين جدا جدا، ومتشكرين للاساتذه اللي شرفونا وقالوا المحاضرات وتشير، ولكل الحضور من الزملاء والاساتذه، ونراكم الاربع القادم باذن الله. شكرا جزيلا.
شكرا جزيلا.
شكرا جزيلا.
مع السلامه.